I think we have enough people here that we can at least begin the organizational meeting. And so I think Senator Johnson has the list of committee members, so I'll ask him to call the roll.
Ryan.
Here.
Parker. Barnett. Blackwell. Blunt. DeBar. Fillingane. Frazier. Harkins. Hickman. Hill. Hobson. McMahon. Parks. Polk. Tate. Turner Ford. Wiggins. We have a quorum.
Welcome back, everybody. Bring the band back together. I think the first order of business is to adopt rules of the committee. Senator Parker.
Thank you, Mr. Chairman. I guess we could go ahead and nominate our secretary of the committee first, if that would be appropriate.
Well, why don't we just do the rules?
Okay. My first motion then would be that we adopt the Senate rules with the exception that the motion to dispense, the motion to reconsider be allowed to be dispensed with on the same day as it's entered.
Those are the rules we operated under 4 years ago. Are there any questions? You ready to vote? All in favor say aye. All opposed, no. The ayes appear to have it. The ayes have it. And as Senator Parker mentioned, we need to elect a secretary. Senator Parker, you have a nomination?
I nominate again Senator Chris Johnson has graciously accepted the gavel, I believe, for that position.
Are there other nominations?
I move the nominations be closed and we accept.
Are there other nominations? Seeing no other nominations, the motion is that nominations be closed and that Senator Johnson act as secretary. All in favor say aye.
Aye.
All opposed, no. The ayes appear to have it. The ayes have it. Senator Johnson, I think I speak on behalf of the entire committee when I say I think your performance over the past 4 years has been acceptable. And so you're back again. I will just say this to the committee. If you'll look around at the members of the committee, it's a pretty good group of folks we've got. Personally, I'm very glad that every single person is a member of this committee. I think it's a good committee. It's very good that we have so many other chairs because much of what we talk about here may involve legislation that goes to other committees. We're having matters that, to say the least, involve judiciary, involve education, and of course, everything we do involves appropriations and finance, but money will be no problem for this committee because we have the chair of finance here who can raise all manner of money and the chair of appropriations who can spend all amounts of money. So he's got all we need right here on this committee. But it's a good committee and I'm very happy to get to work again. We are going to start this year sort of like we did 4 years ago with a series of hearings just to discuss generally healthcare and a number of issues that are facing us as we get ready to look at the next 4 years. I've asked the state health officer, Dr. Edney, to come speak to us today. And I've asked him to just speak on the topic of the state of healthcare in Mississippi, a topic only slightly less broad than the history of mankind since Adam. But Dr. Edney's been nice enough. I see he has a handout, which is always good. So would you like to come up and do you want to sit at the podium? Do you want to sit at the table, just wherever you feel more comfortable? Okay, that's fine. And I think that this committee meeting is being live streamed over one of the internets. I don't know. Dr. Edney. Just proceed however you think best.
Thank you, Mr. Chairman. Thank you, committee members. I really do appreciate the opportunity to give you a briefing on what I just called the agency brief that I developed, started last year and fine-tuned it this year, and this year have broken it down into the state of health for our population, the state of health for healthcare, and then the state of health for your Mississippi State Department of Health. and take you through some good news. And I'm very pleased to bring some positive news to you. And then, of course, the challenges that continue to face us. And basically make sure that you know that we're a resource for you as you go through your important work this session. And as you're running into each individual challenge that falls in our jurisdiction, we will bend over backwards to get you the best information and data that we can, with understanding that we have one agenda at the health department, and that is to protect and advance the health, safety, and well-being of everyone in Mississippi. And we are always happy to help you in your work. So we'll begin with the health of the population. And even with the allotted time, this will have to be a fairly broad overview, but happy to answer questions as I need to. The health of the population overall is about the same. We're scoring really about the same in the Commonwealth report card, which is really what public health entities go by, because it's looking at population health outcomes and looking at all the challenges that we encounter from not just the outcomes that happen, but also the level of the population that is insured, the population that has appropriate access. I have to remind people, having insurance does not equate to access. It makes it easier, but if you live in Myersville, Mississippi, up in my area, then access is difficult. You got to hike to get to any healthcare. And then looking at especially unique challenges impacting specific populations. And unfortunately for us, when we are looking at disparities, we're looking at every population in the state. As I had shown y'all previously, if looking at where our score hits, we're not just 50th in the nation. What really concerned me was how we fall off the cliff on the graph at the end. And here is our white population, and here's our African-American population. And then we also have Hispanics and Native American and the Vietnamese population on the Gulf Coast that are all important populations that we work with. Their numbers are too small to show up with population data, but we still track it. And they are running in here. And the difference between these two dots means that there is a disparity. All a disparity means is a difference in a negative connotation. But so significant. I can handle that. I apologize.
I don't even have my machine on. As best I can tell, we've sent to Caltech to see if we can get someone who knows how to turn the volume up. So, but anyway, if you would speak into the microphone.
Yes, sir.
Thank you.
My apologies. But looking at the difference in those two dots is the amount of disparity between the white population and really the rest of the populations of the state. But I want to point out something to you that's not talked about very much. The entire population is below the all-group median for the nation. So when you look at the scores of every other state, if you're above that line, then you're doing okay. The higher you get above that line at 50th, the better you're doing. And I want to bring to your attention, the white population is below the all-group median, and there's significant disparity between the entire population of Mississippi and those in the Northeast, irrespective of the demographic. So as we all work together, especially with the health department's work to narrow that gap, our outcomes will improve and the whole ship should rise. But what I want to make sure I have before you is the importance that all of our populations in the state need attention, and we are doing that. Let's see, can you advance it for me? So here's our report card that has some good and some kind of the same on it that we'll be releasing tomorrow. And our overall scores are staying about the same. We did move into solid 50th place with maternal death. But I want to get a little bright spot as I'm looking at the 2023 provisional data. I can't give you the numbers because we have to vet them statistically, but the raw numbers for both maternal and infant death look better. So I'm praying that it's the beginning of our trend. One data point does not a trend make, but I'm very excited to have our first data point in quite a while where we're moving those very important health outcomes in a positive direction. Maternal infant remains top priority of the health department. Reason being, it's low-hanging fruit. We don't have to save 5,000 people to move the needle. It's a small number of deaths, relatively speaking, to our top 3 causes of death, but it's quite large compared to the rest of the country and actually the rest of the developing world. So as we are able to save a few women and a few babies, that needle swings. And my goal is not just to improve our outcomes. My goal is to get us off the radar. And every interview that I do, I make sure they know all the work that's being put into this space. And then I tell them, now, if you're a legitimate journalist, you will call me back in 3 years and ask me how we did it. And I will tell them how we did it, how we as a community did it. We'll see if I get that phone call or not, but the outcomes are going to improve. So I want to point out to you some positives. Opioid deaths were down 10% in 2022. We're one of very few states that can say that. That comes through the strong partnership between the health department, Departmental Health, and Department of Public Safety working together to distribute naloxone aggressively, especially on college campuses, and educating upstream as much as we could so that college students and high school students understood the dangers of fentanyl and counterfeit fentanyl that was killing a lot of our students a little over a year ago. And so I'm excited that our opioid deaths are down. Again, it's 1 year, but awful lot of investment's been made there. The main thing I need to see to start going down, though, are the number of overdoses. So we're rescuing a lot of people, but they're still overdosing. And we need to get upstream, so we're reducing the number of overdoses, make sure we're providing appropriate access to care for the treatment of the disease, and not just hitting people with Narcan and then discharging them to the street. But that's a positive indicator. So grateful COVID is off our radar. The number of deaths are, they're not zero, but they're very low, mostly in our older population and sicker populations. But that does not have to be a priority for the health department at this point. It falls into our respiratory illness work with flu and RSV. I want to point out to you obesity. I'm probably more proud of obesity than any of our health outcomes. We've gone from 50th to 45th. Now, I want to make sure you understand how important that is. If we went from 50th or legitimate 60th, if we could go from where we are up to 45th, we're talking about a lot of excess morbidity and mortality being mitigated. So you may say 45th is not that great. Well, my staff keep correcting me that we're going better than that. But that is a huge swing. And it's not, at first I thought it was just people getting fatter than we were, but it's not. It's that plus our trends have steadily gone down for over 4 years now. So we're just, even through the pandemic, we watched our obesity rates drop, which will have downstream effect on cardiovascular. Our usual suspects remain. The number one cause of death is cardiovascular death. That's approaching 9,000 deaths per year. Many of those are preventable, and that number is trending the wrong way. The second leading cause of death is malignancies, which a lot of those are preventable because we have too large a segment of our population that just don't have access to proper screening. But, they don't have access to preventive services. So it's that, that fact drives cardiovascular and the malignancy deaths. And then our third are accidents, which, continue to be an issue that a large coalition continues to work on. Diabetes is a bit better. So, moving from 50th to 48th in diabetes is huge because it has such a pervasive impact on so many health indicators. So with obesity and diabetes both coming up a bit, they're synergistic so that we have more of an impact than either one alone doing it. And HIV continues to trend down. Very, very proud of that. And that includes through the pandemic, and the issue with the pandemic was not that COVID was killing people in those populations necessarily. It was that the healthcare system was overwhelmed and access to routine things was much more difficult in 2020 and 2021. But even with that, obesity, HIV have gone down. And I have to point out the fact that our TB program, although it has no funding, just like minimal level funding, continues to perform very well, and that our numbers have remained flat and stable. And even in the pandemic years, they remain flat and stable, and we are below the national average for TB. That is purely health department work. That is our TB program at the health department, working with our community partners to stay on top of tuberculosis for all of us. So some of our policy solutions for ourselves, for the population to get healthier, we have to improve access, however we choose to do it. And that's, up to y'all's good decisions to decide how to do that. There are many ways to do it. For us, improving access means using our county health departments to the fullest extent that we can. And so we have developed the Know Your Number program, which is where anybody in the state can go into their local county health department and receive free blood pressure or blood sugar testing. And that had to be an appointment. They're not entered into the system. We just take the blood pressure, take the sugar. And if it's abnormal, then we help take care of them and get them into a medical home, which is what they need. We have screened not quite 3,000 folks, and we have seen some very interesting results. I'll tell you about family up in the Delta. I think it was Washington County, Victor. Mom came in for other services. She had two sons with her. One was 13 and one was 16. And our clerk said, well, while you're waiting, would you like us to check your blood pressure and sugar? And she was happy to, and checked all of them. The 13-year-old was hypertensive, which is very dangerous. A 13-year-old with any level of hypertension is going to wind up on dialysis and probably premature death. The 16-year-old had diabetes unrecognized, frank diabetes unrecognized. And so we were able to identify those two and get them into a proper medical home and have those issues tended to. So those numbers are steadily increasing. We're seeing, just widespread uptake of that opportunity, and the program is really just getting started. I'm preaching that we must get out of our silos, and that includes the county health departments, that the county health departments must be part of the community. They must be part of the safety net fabric of the communities that they serve. And that means get outside and be part of the community. and make sure all the providers in the community know the resources we have that we can help them with, and make sure that the uninsured are able to take advantage of our programs, such as our BCCP program, which provides free mammograms and pap smears for uninsured women. The part of getting out of our silos is deploying mobile units in whatever way we need to. And we're going to be using them in our congenital syphilis work, our overall HIV, STD screening work, our diabetes, hypertension screening work, our disaster response work. Any program in the agency will have access to our mobile units, which will be able to go anywhere in the state and extend our reach, especially into communities that may not have as robust access. And we're getting a lot of attention with our community partners for that. And then you may know about our transportation to health program that's very young, but the uptake on that has been robust. It's where we provide transportation through a federal grant that we have that pays for us to bring them to the health department, take care of them, take them to the pharmacy if they need to, and then take them home at our cost. And I think we've provided so far in 2 months, 133 rides. And that is probably outside of poverty, the number one social determinant that we struggle with is transportation difficulties. And so that has been, very well received, and I think it's going to provide some dividends for us. We're also extending our reach with telehealth, and my game plan is over the next several years to increase our provider numbers and just really be able to serve more patients than we ever have. And the combination of transportation to health and our telehealth work and doing some more private sector things that I'm used to in private practice, just kind of going that extra step and calling the patient more than one time, we have cut our no-show rate in half, which means our encounter rate's going up. Okay, so that's kind of an overview of the health of the population. We're still have some challenges, but some things are looking better. And the one thing I would just challenge you with is what I was taught early in my medical education, and most of us in healthcare, that whenever in doubt what to do, look after the need of the patient. If you look after the needs of the patient, everybody else is taken care of. Things fall into place. And so for us to truly reduce our cardiovascular preventable deaths and our malignancy preventable deaths, we just had to find that right solution that we all can agree upon to improve access to care for regular Mississippians so that they have a medical home. And right now we have too many Mississippians that are not in medical homes, not of their choosing. So healthcare systems, we've got some good news and some challenging news, which I'm sure is no surprise. So hospital health is better than it was. And at the health department, that is a good thing. When things are better than they were, that's a win. And the health of hospitals is better than it was a year ago when I talked to you. Through the sustainability grant work, having the audited financials, we were able to determine a total negative impact for all hospitals related to the pandemic of over $700 million. With the sustainability grant, we're going to drop that by 65 million or so. The enhanced MHAP funding is going to be very impactful. I don't know by how much, but the enhanced MHAP formula, I think, will close that gap to a large degree. And but I want to make sure I bring to your attention that out of 103 hospitals, we still have 10 that we could not deem eligible, and mainly because they were in such bad shape before the pandemic that the pandemic actually made them better. made those quarters look better financially, not good. But I can't demonstrate to the feds that they had negative economic impact because their numbers improved. Now, I have no doubt if I look at their numbers for this year, it's going right back down again. So these are hospitals that do need help that we were not able to help with the sustainability grant, but it's only about 10 of them that we're not going to be able to fund. And we'll have that data for y'all, as you're looking at those challenges. It's important to know with enhanced MHAP helping, we have the new problem on the horizon for hospitals with Medicare Advantage. And I'm hearing more and more, especially from rural hospitals, that Medicare Advantage, which are HMO products for Medicare, and their reimbursement rates are much lower than traditional Medicare. Their prior approval processes are more stringent, and the length of care is always much shorter, and that is hitting their margins in a way that it never has before. And more patients are moving to those Advantage programs because they're less expensive and they have some other incentives with them. So rural healthcare remains a challenge. I think you will have some good opportunities in front of you. There will be an opportunity to look at a regional health authority in our state that I've been working with and looking at, and I think has the evidence behind it from the work of other states is very good, and it actually matches some of the work in the 2019 Governor's Task Force recommendations. So you'll have some innovative bills coming before you by others to look at, and we'll be happy to provide any data as you're looking at those things. Physician workforce continues to improve. And I have to give a shout out to Dr. John Mitchell with the Office of Physician Workforce, and thank y'all for investing in that program, which the biggest thing that it has done has been to develop and grow and mature community-based residency programs. And what we see where doctors train is very commonly where they will practice. And last year, the family medicine program out of Greenville generated 4 family medicine docs, 2 stayed in Greenville, the other 2 stayed in the Delta. That's huge. So that program, which is not a health department program, is showing really good results, as are all the rural scholars programs that you fund. Definitely incentivizing students to go into primary care specialties in rural areas, but also the nursing workforce is starting to improve. Still some challenges with nursing education, but it's better. And also, dentists and all of the programs that you fund are showing a positive impact on the workforce. I need to make sure you understand about EMS, because this is the new thing on our radar. EMS is in a fragile state. It is complicated. It, as many of you may know, was established in the late 1970s, early 80s, and the statute hadn't really changed very much, and the system has not changed very much. And we're facing more and more challenges to EMS. And this is a major concern because it impacts our systems of care that deal with trauma, heart attacks, strokes, and have been evidence-based programs that we need to be doing, but it relies on EMS. And now we have the rural emergency hospitals coming online, and there's one for sure that's fully designated, and another one that's very close, and about 4 or 5 more in the pipeline. And these are mainly critical access hospitals that are downgrading to rural emergency status, where they give up their inpatient, they do ER, outpatient, they can observe for up to 24 hours. And at that 24-hour mark, if they're not able to go home, they have to go to a higher level of care, and we have to get them to that higher level of care somehow. So that's another burden on EMS, especially in the rural counties. And the systems of care, they're a burden, but they're an impactful burden that we have to do. And we're looking at 2 new systems coming online, very soon. The way the health department's attacking maternal infant death, in addition to what we've always done, is the Healthy Moms, Healthy Babies program, which is evidence-based nurse home visitation, and the obstetrical system of care, which is also evidence-based. But as we implement that system for maternal and infant death mitigation, we will move to the front of the pack of what states are doing. And I'm very excited about that work. But again, EMS is a key component of that. It is underfunded. The funding mechanisms currently do not work. And the workforce has gotten dangerously small and is shrinking. And so I'm working with the EMS Advisory Council on, all hands on deck on what we have to do for workforce development for EMS, what funding opportunities there are. This was another item in the 2019 task force report that I think, got it right. And in terms of, looking at new ways to fund EMS, I think you will have before you some community partners that will bring the issue of it being an essential service before you, which will be a big debate. And I'll be happy to provide whatever information you need as you look at that. But, I'm just asking for attention to be paid to EMS. As EMS things come before you, really look at them. And if you have questions, don't hesitate to call me and let me help you walk through it. But we need to raise the spending cap on the trauma fund. We're right up against it. The trauma fund's probably going to need some attention pretty soon, so it doesn't become depleted. We're okay right now, but and we've been looking at ways that possibly ARPA funds, could boost the trauma fund and be ways that could be immediately spent and not have to worry about a holdover. So things I'm very happy to work with y'all. And then quickly, health of the agency, better than we were, not where I want us to be, but better than we were. Everything that we do is through the lens of the mission. I wish, I probably, Mr. Chairman, would have been smart for me to have understood the mission before I took this job. That's a heavy lift, but it's an important lift. And I believe that we're up to the challenge. And I'm just gonna be honest with y'all. Those who know me knew I was in private practice for 32 years as I transitioned to public health. And the only way I know to run clinics is through that lens. And I know that not all business approaches work in state government. In fact, there are a lot of things with state government that get in the way of me being efficient and controlling overhead, but it's the environment that I'm in now. But a business approach to public health may sound like an oxymoron, but to me, it's the wise choice, because there is no appetite for funding public health at the level it would take to get us back to the good old days that everybody keeps talking about. And then I preach the good old days are old. We need to be looking forward, not backwards. We need to be looking at how our private partners, what models they're using that work and things that will translate to us. And I can tell you what will translate is efficiency and overhead control, not just spending what's budgeted, but controlling your overhead, and improved billing and much improved collections, and generating revenue ourselves as much as we can. And so for the last 17 months I've been your state health officer, I hit the ground running because I knew we had trouble with sustainable funding for community-based public health. And I see a pathway forward to sustainability that does not impact the state budget, does not impact county budgets. I'll be talking with y'all later as that fleshes out. But that's the path that I'm on for financial sustainability. And I'm not, for us to do 2010 public health, you would have to increase our appropriation by $40 million. And then I wouldn't be able to hire the workforce, because I don't have enough nurses out there to hire. but there are other ways to do things. And so bringing a business approach to public health is going to pay big dividends for public health and help the state budget, and very importantly, help the county budgets, who are under a lot of strain right now. And I can tell you our encounters are up almost 12%. Our no-show rates are down. We've cut those in half. Our provider visits, which are where we can bill Medicaid or now Blue Cross, thanks to your good work last year, and we're probably going to generate about $500,000 of income from insurance companies that before you helped us last year, we just had to eat. You know, all that goes to our bottom line. And then having a much more cost-effective and efficient way to run our clinical operations. And we're moving in that direction. All of our parameters are improving. Billables are up, collections are up. Collections are up now about 5 million per year compared to 2021. And I started implementing the changes August of 2022, and it's paying dividends now. We still have a lot of opportunity there. So in terms of the agency work, we're in the midst of rebuilding our workforce. We were pounded pretty hard through the pandemic, lost a lot to retirement, a lot just moving, out of public health. But I'm rebuilding the workforce for the future. I'm looking to 2030, not 2019. And I'm looking at public health being stronger, being healthier, being more robust, and being available to every Mississippian every day that state government lets us be open. So people will know we're open, they'll know where we are, and they know what we do, and they can depend on us. Whereas over the last year, I can't say that with any amount of certainty, which is unacceptable. And thankfully, we have workforce development grant money that we're deploying to rebuild our workforce. We're also investing in the Office of Rural Health. And I've hired Dr. Jennifer Golson to be our first physician level director. And that office has been charged with becoming a resource center for rural health in all respects. And it has not been, but I'm investing in that at the agency. So a lot of exciting work going on, and we're seeing some results to our good work. Still more to do, but I am encouraged. So, Mr. Chairman, I appreciate the time.
You realize you raised more questions than you answered. I assumed that was.
My time is spent, sir.
I was assumed that was intentional. Seriously, thank you for the overview, and it's a good basis for what we'll be talking about as the years go by. I just wanted to, before I ask for questions, remark about a couple of things that you mentioned. One of which was you were discussing a rate of cancer.
Yes, sir.
And you said one of the problems was lack of early screening. And one of the reasons for lack of early screening was lack of routine access to a healthcare professional for a large number of people. And it seems that that's one concrete example of what happens when there's just, in fact, an awful lot of people who don't have regular access to healthcare.
Yes, sir. And I'm also convinced that this old saying, health is wealth, is for real. Because as I look at the cost of these negative outcomes, and I've actually commissioned a study outside the agency to give me independent information of the negative impact to the Mississippi economy for those top three. How much, and I'm not talking about cost of care, I'm talking about everything. Lost productivity, lost workforce, everything. And I'm afraid of the numbers we're going to be looking at. But as we improve health, I truly believe we will improve poverty. And I don't think I'm being naive about that. It's we, through your leadership, have done it with education, as you've heard me say before. So I fully believe we can do it for health. And I mean, I know education was a heavy lift for y'all, but if we could get from where we are today to where we are with education, oh my goodness. The reduction in disease burden, the reduction in premature death, and look, I'm 62 and I don't think I'm the oldest one in this room. No offense, Mr. Chairman. The life expectancy is 71. I tell folks I worry every day if I'm gonna get back to Vicksburg. These are real numbers that impact real Mississippians. We have the highest rate of preventable death. That means more Mississippians die unnecessarily every year than anywhere else in this country. And these problems have solutions, you know, and I trust your good judgment to get us where we need to be. And I want to help you with whatever data, information, resource you need. You know, with the only lens I have is to try to make it better for Mississippians, which I literally pray for every day on the way to work.
You've just told me for the past month I've been living on borrowed time.
Now, that's my professional opinion. I'm sorry.
Well, that's a cheery thought. You also gave an example, and again, these are just things that strike me as something to think about calling people to remind them of appointments.
Little things, the little things.
And you said people in the private sector do that. And so I've been to the doctor a couple of times here lately, and they do. They call you and remind you, and you get these little things over the internets, you know about the internets. And so it strikes me that one approach is to say, there are people who are coming to the health department who could get health care. It's free. They have an appointment, and they just won't keep the appointment. And therefore, it's their own fault without accepting responsibility, and on and on and on and on. But it's something to think about, to realize that people who are not coming to the health department, who are going to see a doctor in the private sector, paying for that doctor, they too don't keep their appointments. And so the solution is not so much to blame the various individuals for being irresponsible. I don't say that's not a response. I mean, it's not I'm not suggesting that's not an issue, but rather than focusing on that, there's a solution for that, which is to call, which is what private sector people do. I thought that was something to think about as we go through all of this.
Yes, sir. And a lot of our folks, it's usually social determinants that are getting in the way of them getting to us.
You mentioned
No-show rate
transportation.
Our no-show rate's been 50% for a very long time. And I just coming from, private practice, 50%, you can't stay in business with that kind of a no-show rate. And so look for solutions. And I think we have solutions that are starting to help. And so we have more people who previously would have kept missing their health department visit appointments who now are able to keep them. And we'll continue doing what we can to allow those wonderful entities all over the state to be the access points for all your constituents. And I'm determined to serve you folks better. And it's going to take a different way of doing things. But those of you who have experience in healthcare in the private sector will understand what I'm looking at and the things that have to change. And it's not just about saving money and generating more revenue. It's about providing better service, getting better outcomes. And that's what's guiding me. And then you have to remember 70% of our patients are uninsured. That does not mean they're not eligible. It just means they come in the health department and they're not active on Medicaid and they don't have Marketplace. And so Dr. Sutton's team goes to work determining eligibility with them to try to narrow that gap down from 70% to whatever we can get it to. and we're having success there. My goal is, to serve everybody that needs to be served, but, I love my friends at Medicaid, but if they're eligible, they need to be on Medicaid. And so that their care doesn't come out of the state treasury budget. And I would remind you that our agency pays our match. Okay? So whenever we're reimbursed for our services by Medicaid, we turn 25% back around to the division so they can draw down more. So I don't cost Medicaid anything except frustration. But, I'm all about taking care of ourselves as much as we can so that you'll know when I'm coming and asking for help that I've done all I know to do. And I'm not trying to grow the agency. The agency itself, I'm trying to restrain and control. I'm trying to grow the community footprint. And then keep the agency bureaucracy under as much control as I can.
So other members of the committee have questions. Senator Blackwell.
Thank you, Mr. Chairman. Dr. Edney, since you invoked the name of Medicaid, I want to ask a couple of things.
Yes, sir.
One, it was good that our infant and maternal mortality have dropped. As you know, earlier last year, we're finally successful in passing postpartum care. I doubt that action had much to do on these figures just due to the timing. So next year's numbers are going to be really interesting to look at. This year, we're going to tackle the front end of that on presumptive eligibility. And I'd just like for you to tell the committee what your thoughts are on that.
Yes, sir. The most important thing we can do at this point to reduce both maternal mortality, infant mortality, but then also infant health is appropriate prenatal care and engaging prenatal care as early as possible, which is a problem in our Medicaid population. And so we're looking at everything we can do with the agency to try to help women understand that engaging in prenatal care early means you're more likely to survive your pregnancy. And that's what I say. We want to help you not die. And we want your baby to live to reach 1 year of age. And then that baby's got a chance. And I have 3 adult children. I have 4 grandbabies with 1 on the way. And this sweet thing that'll be here in about a month. I want babies in the Delta to have the same chance to have their first birthday as my sweet baby's going to have. I guarantee you my sweet baby's going to have every chance. Do we not agree that all of our babies need the same chance? Which just means that we do what we have to do for those babies that are at really high risk of dying at 6 months of age and all the negative fallout that hits with that. So presumptive eligibility is done in at least 25 other states. It's what the hospitals are able to do. If a pregnant woman shows up and her Medicaid is not active, the hospital treats her presumptively because extremely high likelihood that she'll be eligible for Medicaid, and Medicaid will back bill 3 months. When she goes home, her Medicaid will not be active at the OB until she goes through eligibility determination and enrollment. And in Mississippi, many times our ladies are showing up in the Medicaid population already 5 months pregnant. And if it's going to take another 4 to 6 weeks, which has been our experience in helping to enroll pregnant women, then we're past 6 months, well into the 7th month. And a lot of things have already been set by that point. She may have had syphilis since the first trimester, and that baby's been infected for multiple months, and we're not just now able to find it and treat it. And so presumptive eligibility is not the main issue, but it is an issue. And in my opinion, as your state health officer, who's tasked statutorily to address maternal infant death. That comes from y'all to me. I think we should eliminate every hurdle that we reasonably can. And if it's not reasonable, just tell us why it's not, why the hospitals are able to do it, why other states are able to do it. And it's just one less barrier to prenatal care. And then we got to keep looking at all the causes of why women are not going for prenatal care soon enough. And not accept it, not just say, well, it's always been that way. You know, they can come if they want to. We can have that attitude, but then we're paying for that baby's NICU stay if it survives. It's going to be a low birth weight baby and be at UMC for 3 months. And Medicaid has to pay for that. So I'm full square behind presumptive eligibility, and any other way that we can partner with the division and the MCOs to engage prenatal care early.
Senator Wiggins.
Thank you, Mr. Chairman. Thank you, Dr. Edney.
Yes, sir.
Always appreciate your straightforwardness and cutting through some of the noise that's out there. So thank you. In looking at what you handed out, one of the things that jumped out at me that we always look for good shining lights, I guess. And I noticed on teen pregnancy, teen birth rates, we're still towards the bottom, but you know, 10 years ago, Governor Bryant made teen pregnancy a cornerstone of his administration. And looking at this, the trends are down every year.
That's right.
With a little tick up. And honestly, looking at like in 13 and 14 and then 17 to 18, there's significant drops. What's that attributed to? And then with this little tick up, what can we do to keep the trend going down? What's happening in that?
And thank you for pointing that out, because I'm also very pleased, because the lower that rate goes, the lower high risk pregnancies we're going to have to deal with. Again, Dr. Sutton's team has been working with Department of Education on evidence-based programs that we help with federal funding. And if schools decide to do it, then we have teams that help them with the curriculum, and we help to fund the programs. And, you know, we will continue to work that space as hard as we can.
Is it particular programs, or is it, and I've read that, I guess this generation is less sexually active, but is it also knowledge, or is it a combination of everything?
I think that you nailed it right there. And
Okay.
It's also amazing what happens when you give a little information from a trusted source to somebody. You know, many times they listen, but if you just assume that you can't change it, you know, nothing changes. Your observation is correct that we are still too high. And I was not happy that we had a little blip. It was small, but it was a little blip this, you know, in 2022. But yeah, and if y'all were interested in investing in that space, we will continue to be a partner with Department of Education. You know, the real bang for the buck for all of this, I mean, the biggest return on investment you can possibly make is in early education of our children and public health issues. That, you know, we start at Head Start, you know, and the sooner that we can help teach a child how to be healthy, that it's actually okay to drink water. You don't have to drink Kool-Aid and Cokes, you know, that, you know, some physical activity is good for you, you know, and you start early. Look, I'm old enough. It was, you know, I rode in the back of my daddy's pickup truck and didn't know what those seatbelt things were until I had children, and they came home from school and said, "Daddy, put your seatbelt on." This was in the 90s. I went, okay, because they had been taught about fourth grade. They had been educated about safety restraints. You know, the same thing with tobacco. You know, our successes are impacted greatly when we're able to get to them young and teach them.
Oh, I can't let that go since you brought up early education, but I noticed that 2013 was when we passed, that's when the Mississippi Miracle started, which also included early education, which has a healthcare component in it, the Collaborative Act. And so thank you for saying that.
Yes, sir.
I'm sure we'll talk more about it. Thank you.
My pleasure.
Other questions? Senator Philingane?
Thank you, Mr. Chairman, and thank you, Dr. Edney. Couple
sir.
of questions. I noticed in the packet you handed out, the homicides, death caused by homicide, they did drop from 21 to 22, but we're still a far cry away from the pre-pandemic levels of around 17,700. We're still at 23,700. Do you anticipate that decline continuing post-pandemic, or what is your assessment of the homicide rate?
I think that's a good observation. I do expect it to improve, and especially with Department of Mental Health's good work, with their suicide prevention hotline. A lot of the deaths from firearms are suicide and then homicide, and then a large number of accidents, just accidental discharge that causes a fatality. I think y'all know that we lead the nation in firearm deaths, and there are public health evidence-based programs that have nothing to do with gun control that help. And I'll be honest with you, our bandwidth, like I said, we're trying to keep mamas and babies alive right now, and our plate's pretty full. But that is something that we're going to have to take up together. And like I said, they're public health evidence-based programs that really don't have any political concerns to me as a redneck from the Delta who loves to hunt. These are good policies that we can look at together when y'all think it's appropriate.
So how many of these would be violent crime related in your opinion?
I'll be happy to get you specific. I queried our vital records folks, and the only thing they could give me was CDC, which I don't want to use the CDC data if I have my own data. And there were challenges to tease out from the death certificate data, but I would be happy to get that and get that to you and anybody else that's interested. We can dig that data out for you.
Great. On another topic, the diabetes related deaths and disease within the state, how difficult is it for people to access the new drugs, the Mounjaro and Ozempic and Wegovy, all these semaglutide type drugs that are very expensive? They're also very effective according to all the studies. Are we making use of that in our Medicaid population?
Yes, sir. I want to give a shout out to the division because they typically are early adopters with the formulary of what we need that's evidence-based. And they also recently started approving obesity management medications, which will be very helpful for those of us taking care of the Medicaid population. So I think the division's doing all it can there. The bigger issue, a lot of private insurers do not want you going to the best drug because of the cost. So our physicians and providers usually have to stair step it before they can get justification and approval to use what really works the best. And boy, it drops the obesity rate significantly. They control diabetes really well and drop the BMI.
Well, and heart disease as well, I would think.
Yes, sir.
So is there anything the legislature needs to do to amp that up for us?
Can I think on that?
Sure.
I tell you, the Medical Association probably will have more sensitivity since I've been out of practice for a few years. I talk to my former partners a lot. I talk to doctors a lot. And it is frustrating to know that you have amazing medications that you can't access. And then, of course, the uninsured. I still run my free clinic that I've run for 25 years in Vicksburg. There, I can get the best off the patient assistance program because I know how to do it. But I'm going to tell you, average Mississippian with a college education wouldn't be able to finagle the patient assistance program for these pharmaceutical companies. So One thing I would ask you to do is to pay attention to the 340B legislation that I think will be coming before you, which is extremely important for cost control in rural areas, especially rural hospitals and clinics. And then I will be happy to investigate that a little bit further to give you some more clarity of what doctors and providers are up against if you'd like.
Great. And my last question would be related to the Dobbs decision. We had heard all these
Yes, sir.
predictions that we're going to have this baby boom, post Dobbs because, abortion access will be restricted in the state and therefore we're going to have all these previously unwanted pregnancies now coming to term. Have you seen any of that in your study and your observation at the Public Department of Health?
No, sir, it's a concern of mine. The babies post Dobbs are, reporting out in the 2023 data, which is now going through vetting, but just looking at the raw data, our birth rate continues to slowly decline. So all I can tell you are the terminations being reported to us are drastically down. But I don't know where those pregnancies have gone or what have happened to them. And I don't know if they've gone out of state or if somehow the reporting is not happening like it should. I have no confidence that it's in better family planning. So it's something that we'll have to continue to watch and monitor. When I quoted y'all approximately, I was guessing maybe 5,000 and up to 5,000 was because I knew we were having way more than that terminations and just trying to guess, if we drop our terminations where I thought they would be, which is what happened, what the birth rate should do, and it didn't do it. So that tells me there are other variables.
So have the birth rates, so they were already declining, however,
They were.
pre-Dobbs. So
And they still
have
are.
they slowed, has the decline slowed somewhat, or is it still on track pre-Dobbs?
Through 2022, it's not a drastic, but it's still, the curve is negative. And I'm anxious to see the vetted, right now it's just raw data, but once it's vetted, to see what the 2023 data looks like. And we should have that before too long. I actually look at myself, the raw data of maternal deaths, infant deaths, births, and overdose deaths. I look at those numbers every month.
Great. Thank you, Mr. Chairman.
Since you've raised the issue of a declining birth rate, that's another example of an issue that really has broad-ranging implications for all of society. If you look at what we in Mississippi consider rural areas, on the national level, just about all of us are in rural areas, but even if you get down to what we consider rural areas in Mississippi and look at the population in those places, there is a general decline in population in rural areas. There's a decline in enrollment in schools in rural areas. If there's a decline in birth rates, that population is unlikely to be replaced by in-migration. I think it's the case, I haven't looked at the data, but I think it's the case in the broad view of things. Generally speaking, people are giving birth later in life now than they did 50 years ago. And so when you look at all of those trends, what that says about what the population of Mississippi is going to be like in 20 years is somewhat disturbing. Anyway, other questions?
Well, I can tell you the Edney family's doing its part, sir. Yeah, I got grandbabies everywhere.
Good for you. Senator Blunt.
Thank you, Mr. Chairman. Thank you, Dr. Edney. I saw in your presentation that Mississippi, according to the most recent numbers, has the highest vaccination rate in the United States. Last year, there was a federal court decision regarding Mississippi's law on vaccination is it too early for you to give us an update on the effect of that decision?
We're running right now around 2,300 exemptions, whereas normally would have about 500 medical exemptions each year. And that number with the total school age population is not worrisome, except they tend to congregate. And they oftentimes are in the same school or in the same community, which just means we have to, pay attention. We know where the exemption rates are highest, and we just, keep our monitoring where it needs to be. Because I want all the children safe, the vaccinated and unvaccinated. And we got to take care of both of them. The biggest concern is our little ones with medical exemptions have always been protected by the vaccinated population around them, and it has worked for 40 years. And now we're putting chinks in that armor. So children with juvenile rheumatoid arthritis or type 1 diabetes or some, or undergoing cancer care, we still got to make sure that we're protecting them if they're not medically appropriate for vaccination. And, there's an outbreak right now in Pennsylvania. Now, if that happened in Mississippi, we wouldn't have the same problem because, having the authority to quarantine. And that's going to be critically important. If there's a measles outbreak, we've got to protect all the children. That just means the active cases and exposures stay home from school through their quarantine period, and they go back. And we just do simple public health measures that didn't happen, in Philadelphia, then we'll be okay. If we are staying below 3,000, which we probably won't, then I really don't have much worry. If the further north of 3,000 will give me more concern. And I just have to remind y'all, this is an area of public health we've never had to spend money on. We haven't had to do vaccine education. We haven't had to do measles outbreak control or diphtheria, pertussis outbreak. We haven't had any outbreaks since I was a kid.
And when did that court decision take effect and become the law in the state?
Well, it's not the law of the state. I protected the law of the state by complying with the court order to develop a religious exemption.
Okay.
And so the law stands as is. It just now has a religious exemption granted by the health department to the Board of Health in compliance with the federal court order. That was July the 15th. If I was told very clearly by the federal judge, if I did not comply, then his next step would be to strike the law.
Right. Okay. July, you said, and that covers all vaccinations in the state for any purpose?
The ones that are on the school list.
Okay.
The big five.
Right. Okay. Thank you.
Thank you.
Other questions? I don't see. Thank you again, Dr. Edney.
Thank you.
This was a very good opportunity to give us an overview of sort of where we may be headed over the next several years.
Yes, sir, Mr. Chairman. Thank you very much. Thank y'all.
Thank you for coming. I would say the committee, I overlooked introducing my House counterpart, Chairman Sam Creekmore, who I've now spotted back there. As you know, Mr. Creekmore's family is from Amory. If any of you want to stop by my office, among other things in there, I have a 1964 panorama, the year his father finished school. It's got his father's picture. It's got his mother's picture. My father was on the school board. It's got my father's picture. And Jimmy Burroughs' pictures in there too. So it's got Joe Burroughs' father's picture. It's got lots of pictures of parents in that yearbook. But I look forward to working with Chairman Creekmore. We worked together on the mental health legislation last year, and that was a very productive thing. So thank you for coming. You're always welcome. And you have floor privileges and go wander around the floor anytime you want to. I don't think have got assigned committee meeting times yet. Our assigned time was at 3 p.m. on Tuesdays and Thursdays. And so I'm sort of assuming that we'll be meeting at 3 PM on Tuesdays and Thursdays until I'm notified otherwise. We will not be meeting next Tuesday because I have obligations in Amory, but we will be meeting and have another hearing at 3 PM on Wednesday, which I think is Wednesday, the 24th, if some of you have calendars or can add. And having said that, thank you all for coming. I'm so very glad you're all on this committee. Is there a motion? We have a motion to rise and report. All in favor say aye. Opposed, no. The ayes have it. Thank you. Thank you.